everyone. So this is Rasha here. I am part of the core team of the Association of Women Surgeons AUB, and I'd like to welcome you to another session of our surgical lecture series. So first of all, we hope you're all enjoying our sessions and we hope you're learning a lot. The sessions we're providing are not only applicable to the surgical setting, but they're also very useful for general medical knowledge and the management of basically any patient on the floors. So for today, it's an honor to introduce our speaker, Dr. Sally Sarkis.
Good morning.
She's a third-year general surgery resident at AUBMC. She completed her undergraduate studies in biology with a chemistry minor, and she obtained her MD degree from AUB as well. And she's also considering specializing in vascular surgery. So before we begin, I'd like to remind you all to keep your microphones muted and specify any questions that you might have in the chat box. And I'll leave the rest to Dr. Sarkis.
Okay. Thank you everyone for the kind introduction and thank you for being here today. Whenever we have a trauma patient, I believe everyone have already heard enough about primary survey. Primary survey consists of. So a primary survey usually includes the ABCDE that all of you are aware of. So in the airway, we usually assess the patency of the airway and the potential difficulty of intubation. We need to manage the O2, we need to manage to make sure that the patient is not hypoxic. And if there is any problem with the saturation, we need to consider early intubation. And if the patient has difficult airways, in that case, we need to get the team of difficult intubation like anesthesia and ENT to get control over the airways and sometimes even have a tracheostomy for the patient. Breathing assessment, we need to assess how easily the patient is breathing. So is there any tracheal deviation? Is he hyperventilating? Is he using any accessory respiratory muscles? Because all of these will give us an idea, basically, about how likely this patient is likely to fail in terms of respiration and in terms of breathing. At this point, any patient with compromised airways, for example, a patient that we suspect is having intention pneumothorax, who does not have equal chest rise, who has no breath sounds on one part of the lungs, will require decompression, for example, of extension pneumothorax, or for example, chest tube insertion for evacuation of significant hemothorax that is compressing the air, the trachea, and causing any mediastinal shift. I'm just going fast over these concepts because you've already heard about them. We'll be going over details later on about when to intubate, when not to intubate, and all this. C is circulation. So in this case, you need to assess for the pulses, you need to assess for the level of consciousness of the patient. So a patient with who is unconscious may have compromised circulation and blood flow to the brain, causing his level of consciousness. We assess the skin color, the temperature, the capillary refill. We may check also for early signs like mottling, who indicate hypoperfusion. And of course, we need to have a look at the vitals. So a patient who is becoming hemodynamically unstable with tachycardia, hypotension, is definitely having circulatory compromise. Hemorrhage in this case may be either obvious, for example, a patient with obvious signs of bleed, for example, with a penetrating injury, let's say a knife, and he's bleeding from his wound. And they may also have concealed hemorrhage, and these are the hemorrhages we not worry the most about, but they are usually more serious because we don't know where the patient is bleeding from. And this is what we usually encounter in patient with blunt trauma rather than patient with penetrating trauma. And here, the first thing we need to do is to control the hemorrhage, source control. control the bleeding, control and restore the volume whenever controlling the bleeding is not as soon as it may sound. And the fourth thing we need to have on the primary survey is disability. So here we need to assess the Glasgow Coma scale of the patient. It's a 15-point score that we'll be going over. We need to assess his pupils. For example, a patient with unreactive pupil is already compromised. He already started to have, for example, brain herniation from an increase in intracranial pressure, and this patient may not be salvageable. This is very pertinent in patients, for example, this may be very pertinent in patients that come as part of a massive trauma, for example, something that we had already at the Beirut explosion. So patients who came in with unreactive pupil or who already were in extremity and we think we could not salvage, were patients who were not attended to first. We attended mostly to the patients that we thought were more salvageable or had a better prognosis. And as per the management, and then the management will mostly depend on preventing secondary injuries. What does the secondary survey include? So I have this slide here on purpose, and it's very cumbersome, I know, to give you just one idea about the secondary survey. So the secondary survey is inclusive, very inclusive. It is really a head-to-toe physical exam where you need to check for even very simple lacerations and the scalp to amputation, to a near amputation. You check for all the pulses, you double check on your heart and lung physical exam. Because patients who are not in extremity, for example, patients who are not failing, this is what will guide the second step in the management of this patient. So as part of the primary survey, I mentioned the Glasgow Coma scale. So this is a 15-point score. The most important predictor or prognostic factor in the Glasgow Coma scale is mostly the motor response. So patients with a good motor response are likely to have a better prognosis than other patients. And it gives a better idea about the prognosis of this same patient, whether he has a Glasgow Coma scale of 12 and the 12 points are from just simply eye-opening and verbal response rather than from motor response. So during this presentation, I'll be sharing with you two case scenarios. We'll go over the case and we'll try to analyze them by step, and I'll give you a bit an idea about how I look at a trauma patient when we get called to the trauma bay. So we have here a 23-year-old patient. He was a restrained driver with a head and motor vehicle collision with a truck. His vitals show slight tachycardia. His heart rate is 110. He's hypotensive. His respiratory rate is relatively fine. And his Glasgow Coma scale was 6 at the scene. So usually if we were outside Lebanon and we had better EMS facilities, this patient needs to be intubated at the scene. So any patient with a Glasgow Coma scale less than 8 needs to present to the ED already intubated. This rarely happens here in Lebanon because we don't have these facilities and we don't have trained personnel in the EMS facility. So usually this patient will get intubated directly in the ED before doing anything else. When he arrived to us, he was more tachycardic, more tachypneic, and even more hypotensive. And he was slightly hypothermic. On initial inspection, he had a forehead hematoma and laceration with bony deformities of the left cheek, which gives us an idea that this patient definitely, as you can see, the patient is unconscious. So we cannot have a detailed history to have a better idea on how to proceed with management. So we need to rely on our either by the history that we get told by the EMS facility or a friend or an eyewitness at the scene, or simply by looking at the patient. So this patient with significant forehead hematoma and laceration is likely to have a significant traumatic brain injury. He had decreased breast sounds on the left with soft tissue crepitance. He had a stable pelvis and a 10 centimeter laceration over the left, over the thigh and the knee. So usually we'll go over each point, and I will tell you after every observation what are the things we need to do. So as you can see, this is a trauma patient. He arrived at the trauma bay. There are a lot of people there. We usually have an emergency physician. We have a team leader who is the ED attending. We have a nurse who usually takes care of taking vitals, giving, inserting an IV, starting a transfusion whenever indicated, inserting a Foley, inserting a gastric tube. Now we have an inhalation therapist in case this patient comes in needing intubation, as is the case of this patient. And we have the trauma physician, which is in this case me. We usually conduct the primary secondary survey, we perform any procedure, and here we automatically do a fast exam. So what is the next step in this patient? So patient, as I already told you, came in with a Glasgow coma scale less than 8. So this patient definitely needs to be intubated directly, either at the scene or whenever he arrives to the ED. This patient is already in extremity. As you saw, he is already tachycardic, he's hypotensive, and he has a complete loss of consciousness. We have already two main focus. We either have the traumatic brain injury, or we have the possible tension pneumothorax. So the tension pneumothorax, and I'm saying here tension pneumothorax because it's already causing hemodynamic instability. So the patient is already hypotensive. So in that case, we may allow ourselves to insert a chest tube or to do decompression without having a chest X-ray. This patient is in class 3 shock. So we may allow ourselves to insert a chest tube rather than do a chest tube decompression, specifically because the mechanism of injury is not sure. So this patient may be bleeding, and decompression, simple needle decompression, may not help him much. And let's say we inserted the tube and the patient is, and what's the next step? We intubated, we inserted the tube, and next we need to resuscitate the patient. We have three main concepts whenever we are resuscitating any trauma patient. First of all, you need to be aware of a relatively new concept, which is permissive hypotension. So what is exactly permissive hypotension? So a normal systolic blood pressure or a normal map in a regular patient would be a map of 60 to 65. However, in trauma patients, sometimes we allow them to be slightly hypotensive because this has been shown to have improved outcome, and I will show you shortly an algorithm about how permissive hypotension may help trauma patients rather than being detrimental. We need to minimalize crystalloids. So just give the right amount of LR fluid rather than NSS, because NSS has been shown to have significant acidosis, which will get the patient into a visceral coagulopathic cycle. And I'll also go over this in detail shortly. And we need to have a balanced transfusion of 1:1:1 product ratios. So what about the permissive hypotension principle that we have? So whenever a patient presents with uncontrolled hemorrhage, we need to look at the blood pressure and decide what is our blood pressure target. In a patient with uncontrolled acute hemorrhage, the blood pressure target is not a normal blood pressure. It is a relatively low blood pressure because if we give a lot of fluids, if we transfuse a lot, we will cause a hemodilution. Hemodilution will result in more coagulation disorder. The more the coagulation disorder we have, the more the patient will become anemic, hypothermic, and hypoxemic. And this will be counterintuitive, will be counterproductive rather than counterintuitive, counterproductive, and will lead to more bleeding or rebleeding. Another mechanism by which massive transfusion and targeting annual blood pressure may be detrimental is through the mechanical effect of the fluid volume that we give. So the fluid volume that we give may have a mechanical effect on the vascular clot, and it will dislodge the vascular clot, resulting in more and more bleeding in those patients. So any trauma patient needs to be assumed to be coagulopathic. And a lot of times we are the ones who are inducing this vicious cycle. So a patient presents with acute hemorrhage. I will give you a typical scenario. We start with IV fluid resuscitation. Typically, we give 2 liters of LR. We start with blood transfusion in a 1:1:1 ratio. And a lot of times the patient is hypoxic. So what will the fluid resuscitation do? The IV fluid resuscitation do? So the fluid resuscitation will result in dilution of the coagulation factor, will result in hypothermia, and will result in acidosis. As I said, even despite the use of LR, we still have a risk of metabolic non-ion gap metabolic acidosis in patients who get significant transfusion. They become hypothermic because the fluid we are giving is below the temperature of the body, and we will have a dilution of the coagulation factor, despite the fact that we will be transfusing blood and blood products. Transfusion will also result in hypothermia, acidosis, and hypocalcemia. And hypoxia will result in acidosis. All these 4 factors will result in more coagulopathy. As you all know, calcium is a very important mediator in the coagulation cascade. Acidosis, or through the pH, will affect the pharmacodynamics or the pharmacokinetics of the enzymes that are part of the coagulation cascade. And in that case, what will happen is that the coagulation cascade will function in a suboptimal way. Hypothermia is also very important. So the idea behind this algorithm is to tell you that the body functions optimally in its physiological state, with normal temperature, with normal pH, and with normal electrolytes. Anything that will disturb this will disturb the coagulation cascade. And the coagulation cascade is very important in patients with acute hemorrhage, because if I am transfusing, regardless of how much I am transfusing, if this patient cannot form a proper clot to stop the bleeding, I am not helping him. I am being counterproductive. So we've talked about the resuscitation in this patient. We've already inserted a chest tube, and let's say I corrected his hypothermia. I inserted a chest tube. The chest tube relieved the tension pneumothorax. I don't have blood from the chest tube. He does not have a hemothorax in his chest. What are other locations this patient may be bleeding from, or other sources that may be causing his dynamic state? So this patient could be having a hemorrhagic shock from somewhere else, not from the chest, since we already have a chest tube and it's not giving any blood. Let's say from the abdomen. This patient is unlikely to have a tension pneumothorax in this case, because he already had a chest tube on and he's still in extremie. He may have a neurogenic shock. So any blunt trauma patient with trauma to any level above C7 is likely to could be a neurogenic shock, and we'll discuss the approach to the management. He could have a blunt thoracic injury causing a blunt cardiac dysfunction, or a severe traumatic brain injury that we need to address as soon as possible. So what are different types of shock? So here, if we want to summarize it, this patient can either die from a neurogenic shock, a hypovolemic shock, a cardiogenic shock if he has a cardiac dysfunction from his brain, from his blunt thoracic injury. So, and usually in patients with trauma, they are either cardiogenic, hypovolemic, or neurogenic. Patients with cardiogenic shock have a decreased cardiac output and a compensatory increase in heart rate due to cardiac dysfunction. Their CVP is usually elevated. All the blood is in the heart and it cannot be pumped somewhere else. And there is a backward pressure into the lungs, which will cause an increased pulmonary capillary wedge pressure. As a compensatory mechanism, these patients will have an increased systemic vascular resistance to maintain perfusion as much as possible. However, they will be hypoxemic because despite the increase in systemic vascular resistance trying to maintain a certain flow, the oxygen demand is not being satisfied. The difference between a cardiogenic and a hypovolemic shock is only in the pulmonary capillary wedge pressure. So a patient with hypovolemic shock have a low pulmonary capillary wedge pressure because the decreased cardiac output is not from a myocardial dysfunction, it's from a low intravascular fluid state. And they have also a compensatory increase in heart rate. However, the pulmonary capillary wedge pressure is low because there is no blood or backward pressure from the blood in the heart, resulting in this increased pulmonary capillary wedge pressure that we saw in the cardiogenic shock. They also have an increased systemic vascular resistance to attempt to maintain perfusion as a compensatory mechanism. Patients with neurogenic shock have an autonomic dysfunction, they have a sympathetic dysfunction, and everything is low. The cardiac output, the heart rate, the pulmonary capillary wedge pressure, the systemic vascular resistance, and the O2 saturation. The systemic vascular resistance in that case cannot be elevated because the sympathetic tone of the vessels is absent. So there is no compensatory mechanism for the body to compensate. So what is the cellular pathophysiology of any type of shock? So all types of shock are detrimental and will eventually lead to the death of the patient through inadequate tissue perfusion. So inadequate tissue perfusion will result in hypoxia, energy deficit, which will eventually result in anaerobic metabolism and lactic acid accumulation, resulting in metabolic acidosis. And as I already said, whenever we have acidosis, everything downward will be dysfunctional. All the enzymes in the body or the coagulation factors in the body, everything else will be dysfunctional. In addition, metabolic acidosis results in vasoconstriction. It results in decreased precapillary sphincter tone and peripheral blood pooling because epi and norepinephrine, which are the sympathetic mediators in the peripheral vasculature, cannot maintain a good tone if the conditions are suboptimal, meaning if the pH is low. They need a normal pH to function optimally. This will result in decreased tissue perfusion, and the earliest sign of inadequate tissue perfusion will be a decreased urine output as well as an increased heart rate. Downstream the cascade where the patient will die. This is mediated by cell membrane dysfunction, lysosomal and toxin release, resulting in significant endothelial and capillary damage with apoptosis. So what are the classes of hypovolemic shock? We have 4 classes of hypovolemic shock, and I know this table may be a bit cumbersome, but to make it easy on you, and the way I memorized it, is that a patient with class 1 hypovolemic shock has everything normal. So she lost up to 50% of the blood volume. However, the blood pressure is relatively maintained. So in some cases, we may have an increased blood pressure because they are post-trauma and they may be in pain, for example. The heart rate is normal. They may start having an increase in the pulse pressure. However, everything is normal. So the take-home message, you can lose up to 15% of your blood without having any signs or symptoms. Class 2 hemorrhagic hypovolemic or hemorrhagic shock is when patients lose up to 25% of their blood volume, and this patient will start exhibiting signs of tachycardia and decreased pulse pressure. Patients with class 3 hemorrhagic shock have a significant decrease in blood pressure and they become tachypneic. Class 4 patients who are, these are patients who lost more than 40% of their blood volume. They have significantly decreased blood pressure. They are very tachycardic. The heart rate is more than 140. The pulse pressure is absent or very low. And they're very tachypneic. The respiratory rate is more than 40 in these patients. So what is the difference between a neurogenic and the spinal shock? Something you need to all be aware of. So I'll skip a slide and then I'll go back. So neurogenic shock needs to be suspected whenever a patient has a high cervical spine, a high spinal injury, cervical or up to the mid-thoracic, to the T6 level. So basically any injury above the nipple line. This could be either blunt or penetrating injury. Patient with neurogenic shock, the key element is sympathetic dysautonomia. So they will have arterial hypotension, bradycardia, hypothermia, and they may also have signs from the shocked medulla of the spinal cord, and they are paraplegic, they have hyperextensibility, and they have abolition of all their reflexes. But what is the difference between a neurogenic shock and a spinal shock? Something that will help you remember the difference is that neurogenic shock of the shocks that we mentioned in the previous table, which are all related to the hemodynamics. So in neurogenic shock is due to a disruption of the autonomic pathway with loss of sympathetic tone and vasodilation. Whereas a spinal shock is not from an autonomic dysfunction, it's from a peripheral neuronal problem where the neurons become temporarily unresponsive to brain stimuli. And the sensation and reflexes below the level of the injury may be lost in those patients. Let's talk now about blunt abdominal trauma. So a patient presents with blunt abdominal trauma, and by blunt I mean non-penetrating abdominal trauma. He will be either hemodynamically stable or hemodynamically unstable. Let's go for a patient that is hemodynamically stable. A patient that is hemodynamically stable does not need a test, a fast test. He needs a more specific test. He doesn't need a high sensitivity test. He needs a high specificity test. So in facilities where a CT is available, this is the gold standard. If a CT is not available, we may resort to a fast or a deep peritoneal lavage, which I will be talking about shortly. And then if the fast is positive, if the DPL is positive, or if the CT is negative, is positive, then all these are indication to proceed with surgery. In patient with hemodynamical instability, the test of choice is a fast because it's an easy test that can rule out major intraabdominal hemorrhage. And I say major because it cannot detect minor bleeds in the abdomen. If the fast is available and it's positive, we proceed to a laparotomy. If it's negative or equivocal, these patients may need a deep peritoneal lavage. And as you can see, in patients who are hemodynamically unstable, CT is never part of the algorithm. So whenever in an exam or even in real life, a patient with hemodynamic instability presents and they ask whether they need to do a CT or not, the answer is always no. So you don't do a CT for a patient that is hemodynamically unstable, because even when the CT is in the ED, at some point while the patient is undergoing the imaging, the patient is not under your eye, you cannot observe this patient. So patient with a fast, with a negative fast or an equivocal fast may, negative or equivocal may need a DPL. If it's positive, we proceed to a laparoscopy. So how do we do a deep peritoneal or lavage or a diagnostic peritoneal lavage? It's performed through an intra-umbilical incision unless the patient has a pelvic fracture or is pregnant. In that case, we will go to a supra-umbilical incision to do the diagnostic peritoneal lavage. We need to insert a catheter through a Seldinger technique. This is a technique where you would introduce a needle and then the needle is exchanged over a catheter, which will have a blunt end so that it does not injure any viscous, and it's tilted at 45 degrees from the surface of the abdomen, and we try to aspirate fluids. So we need to attempt to aspirate at least 10 ml of intra-abdominal content. If the patient is a positive DPL, means that we aspirated 10 ml of frank blood, fresh blood. If we cannot aspirate 10 ml of intra-abdominal content, or let's say the intra-abdominal content is just serous or acidic, in that case we need to flush the abdomen with 1 liter of saline and re-aspirate. If the aspirate contains more than 10 to the power 6 red blood cells per cc, if there is food particles, if there is bile, if there is bacteria, if there is more than 500 white blood cells per cc, then this is considered to be a positive DPL. And a positive DPL is an indication for a laparotomy. So what are the injuries that can be missed by a DPL? So a DPL misses a retroperitoneal bleed, because as you can see in this image, we don't go into the retroperitoneal space. This is an intraperitoneal diagnostic lavage. So it will miss definitely retroperitoneal bleed, and it will miss a contained hematoma. So if there is no active hemorrhage into the abdomen and the patient has a contained hematoma, then we are unlikely to see anything on the DPL. One advantage of the DPL over the FAST is that it is more specific or more sensitive in diagnosing holoviscous injury. Because holoviscous injury will manifest as either food particles or very small amount of bile in the abdomen, which may be missed because a FAST can only detect fluid when it's more than 50 to 80 ml. So any subtle fluid in the abdomen cannot be detected. Another problem with the FAST is that in obese patient, we may have obstructed view, or we may have difficulty in performing FAST, which is a focused abdominal sonography of trauma. And another problem with the FAST is that it's operator dependent. So what do we check in a FAST? So we usually do an ultrasound. I believe many of you have seen a FAST in the ER whenever a trauma patient presents. So we examine the perihepatic fossa and the right upper quadrant. We examine the perisplenic fossa and the left upper quadrant. We examine the pelvic fossa just below the periumbilicus. Not below the peri. Actually, it's at the mid inguinal. If we take points in the mid inguinal ligaments and we join them, this is exactly where we need to have our probes, just above the dome of the bladder, and we usually see the space between the dome of the bladder and the rectum. And we need to have a pericardial view where we put the probe just at the edge of the sternum, lower edge of the sternum. So fast, as I already said, would miss a retroperitoneal bleed and would miss a hollow viscous injury. It will not miss a hematoma, however, a contained hematoma, which will show as a cyst. And in trauma patient with a cyst or suspicion of cyst or suspicion of a contained fluid collection, the first thing on your differential would not be a cyst. The first thing on your differential would be a hematoma from the trauma that patient had. Who are the patients that need to be CT? So any patient who is stable, who does not need to go directly to the OR, or who does not need to be investigated through a FAST or a DPL, and with a significant trauma, depending on the mechanism of injury, needs a CT. So patients who do not have these characteristics but will undergo general anesthesia for any other problem. For example, the patient came in with complete devascularization of one of his extremity and needs to go to the OR. He cannot be monitored by a serial physical exam. Patient with closed head injury who needs to have craniectomy for decompression. Patient who are intoxicated, who cannot have a reliable physical exam because they are unaware, who are paraplegic, who have distracting injuries, very painful injuries somewhere else. Patients also who have hematuria need a CT scan. If a patient needs a DPL and the DPL turns out to be negative and the test is unavailable or is already negative, we need to do a CT scan because for you to think that this patient needs a DPL, it means that the mechanism of injury is already significant enough. The patient is already relatively unstable or not fully dynamically stable, then this patient needs a CT. What are the injuries that can be missed on CT? Hollow viscous injuries and diaphragmatic injuries are typically missed on CT. The gold standard for diagnosing a diaphragmatic injury is laparoscopy. However, diaphragmatic injuries are not very common in blunt trauma. They are only present in 35%. So only 35% of diaphragmatic injury are of blunt trauma. 90% of those are from motor vehicle collision. Diaphragmatic hernia, as I said, is diagnosed via laparoscopy. If the suspicion is high, despite a negative CT or despite a negative chest X-ray, and it's more common on the left rather than the right side. Now I'll be starting about blunt specific injuries and blunt abdominal trauma. So here I'll be talking about retroperitoneal injuries or retroperitoneal hematoma. And this table has penetrating and blunt injuries. We'll focus more about blunt injuries. So the take-home message from this slide is that any zone 1, meaning this is zone 1, so it's retroperitoneal. It contains the aorta, the IVC, and the takeoff of the renal vessels and the iliacs. So any zone 1 hematoma needs to be explored regarding anything else, because this definitely entails a major vessel injury. Whereas zone 2 and 3, which consist of the flank area and the pelvic area, don't always have to be explored. We would explore blunt hematomas in zone 2 and 3 whenever we have active hemorrhage or whenever we have pulsatile or expanding hematoma. The approach to these hematoma is also listed in this table. I will not go over it. It's a bit advanced at your level. Second, I'll be talking about liver injury. So we have different grades of liver injury, and they are classified based on the surface area involved by the laceration, the size of the hematoma, and the presence or the absence of vascular and injury or parenchymal disruption. So what are the indication to operate on patient with liver injury? So hemodynamic instability, peritonitis, and transfusion dependence are indication to operate on patient with suspected liver injury. The approach is to fully mobilize the liver as early as possible, then start packing. We usually do not pack within the laceration. We pack around it because packing the laceration itself, يعني بقلبها, would result mostly in disruption of the clots that are already forming. Then we need to attempt to control the bleed after packing, and control of bleed occurs usually through a posterior pressure by controlling IVC injuries, intrahepatic IVC injuries, or the Pringle maneuver. The Pringle maneuver cannot control, however, hepatic vein or IVC injuries. A repair depends on the grade. So for low-grade injuries, we may attempt packing, cauterization, oversewing, or approximation of the laceration, and ligation of individual hepatic vessels if they can be identified. Whenever we have devitalized tissues, we need to resect those tissues, even if the resection is non-anatomic. And for grade 3 or more injuries, we need to drain because any biliary spillage is a risk factor for the development of a biloma or abscess that can be detrimental to the patient later on. Something I want you to know is that whenever they ask you about controlling liver injury, and one of the options is, for example, hepatic artery ligation. So this is definitely a wrong answer. The hepatic artery cannot be ligated. Any hepatic artery ligation, even by mistake, will be complicated by a biloma and abscess formation. The second type of solid organ injury associated with blunt trauma is splenic injury. So again, here we have different grades, grade 1 to 5. And depending on the grade, we may attempt conservative versus operative management of the patient. So these patients will have left upper quadrant fullness, they have generalized peritonitis. They also need to be considered in patients with lower rib trauma on the left side. Splenic injury may be diagnosed by FAST, as we already mentioned. A lot of patients can be managed conservatively. So for any patient with who is hemodynamically stable, the next step after suspecting or diagnosing splenic injury is to do a CT, because a CT scan, a CT angio specifically, will give us an idea about the grade of the injury and the possibility versus our inability to control, to manage this patient operatively or not. 60% of patients with splenic injury will fail conservative care within 24 hours, and 90% will fail within 72 hours. However, it's worth the shot. The gold standard is angioembolization, and it has a high rate of success. And whenever angioembolization is performed, it increases the success rate of non-operative management in these patients. Indication for surgery include, of course, instability and failure of conservative management. Patient would have an expanding hematoma or continuous symptoms, or an expanding pseudoaneurysm, for example, despite the conservative management. So in general, a grade 1 can be managed by cauterization or hemostasis. A grade 2 to 3 is managed by suturing or mesh, and a high-grade injury, anything above grade 4, is managed by splenectomy. But splenectomy may be attempted in certain patients, specifically in the pediatric age group, whenever the patient is hemodynamically stable. So if the question stem gives you a hemodynamically unstable patient, and one of the options includes either angioembolization or partial splenectomy, this is definitely a wrong answer. You don't attempt a partial splenectomy in a hemodynamically unstable patient, because this is a very technically demanding procedure and time consuming, therefore. Pancreatic injury, so again, we have different grades of pancreatic injury, and they all depend on the location, whether it's a distal pancreatic injury involving the tail or the body, or a pancreatic head injury, and whether we have main duct involvement. So any pancreatic injury with main duct involvement requires operative intervention. So this would be a grade 3 or above pancreatic injury. Anything else can be managed conservatively. Whenever we diagnose a pancreatic injury intra-op, anything that is involving bile duct injury and is to the left of the superior mesenteric vein needs to be managed by distal pancreatectomy and splenectomy. Anything to the right of the superior mesenteric vein can be managed by drainage or suction. So a mnemonic that I use to remember this is that head and body injury, so you suck the head, so you drain the head of the pancreas, and a tail injury can be managed by distal pancreatectomy. In certain cases, where we have a massive disruption of the pancreatic head, we may need to drain with possible pyloric exclusion and pancreatic duodenectomy. However, this is reserved for very severe cases and patients who are whose pancreas is already fully infarcted, for example. So this is a schematic. So again, anything to the left of the SMV can be managed by pancreatectomy and splenectomy, as long as the duct is involved. If the duct is not involved, even here we may attempt drainage. Let's go now to traumatic brain injury. So something you already know, I'm sure, and you need to keep it in mind is that what's the formula for the cerebral perfusion pressure? So cerebral perfusion pressure is the mean arterial pressure minus the intracapillary pressure. So any patient with an elevated intracapillary pressure would have a decreased cerebral perfusion pressure and hence hypoxia to the brain. So in those patients with suspected increased intracranial pressure or suspected traumatic brain injury, the goal of therapy is to keep the PaO2 above 60 and hence the saturation at 100%. No hypoxia whatsoever is tolerated. The systolic blood pressure needs to be maintained above 90. And this is where we go slightly above the permissive hypotension goal of management. Hypotension, anything below 90 has been associated with more than 50% mortality in those patients. We need to maintain normothermia, euvolemia, and if the patient has a central line, this would correspond to a CVP of 8 to 15. And we need to keep the head of the bed elevated. We need to sometimes allow short periods of hyperventilation to decrease the CO2 and hence cause vasoconstriction to decrease the intracranial pressure. We may also use mannitol or other hypertonic solution to generate osmotic diuresis. And we also use phenytoin for the first 7 days in these patients for seizure prophylaxis. Anything more than 7 days has no benefit. So seizure prophylaxis is only used early on in the early post-traumatic period. Now let's go to a second scenario so that you don't get bored a lot. And here we will tackle specifically blunt thoracic injury. So we have a 22-year-old patient with motor vehicle collision to a tree. When he geared away from another car on the highway, he was wearing a seat belt and the airbag was deployed. His vitals are relatively stable, 110/80, heart rate of 115, respiratory rate of 28, and the saturation of 92% on 4 liters nasal cannula. He has a good Glasgow Coma scale of 14, so he does not need intubation, and we are less worried about any intracranial process. Pertinent finding on the primary survey included decreased breath sounds on the left. Secondary survey was negative. And as you can see here, we did a chest x-ray. And we did the chest x-ray here because the patient is stable. There is no indication to rush and insert a chest tube for the findings of a decreased breath sounds because the patient is not in extremity and he will be able to tolerate the procedure, the diagnostic procedure. So on chest x-ray, we have left multiple rib fractured, we have a large pulmonary contusion, we have a left pneumothorax and a widening of his mediastinum. So for the left multiple rib fractured, this should alarm us to suspect a solid organ injury, specifically the spleen, something we already mentioned for the previous case. Large pulmonary contusion, left pneumothorax, and a widening of the left mediastinum. These are all findings of blunt chest trauma. So what will kill this patient? So in patients where we suspect or we know that we have a blunt chest trauma, we need to suspect a tension pneumothorax, which is less likely here. The patient is not hypotensive, he is slightly tachycardic. This could be from the pain, this could be from a slight bleed, grade 2 or class 2 hemorrhage. Unlikely to have a massive hemothorax, as we already said, because a massive hemothorax chest can accommodate up to 3 liters of blood. So a massive hemothorax with 3 liters of blood would be already more than 40% of the blood volume of the patient and would already be a class 4 hemorrhage. We should suspect a blunt cardiac injury, myocardial rupture with a possible cardiogenic shock, a thoracic aortic disruption, which is the second leading cause of death in patients with blunt thoracic injury. We should suspect an air embolus or injury to major vessel, including the thoracic aorta. And this is congruent with the finding of a widened mediastinum. Other injuries include rib fracture, isolated sternal fracture, pneumothorax with a tracheobronchial injury or fistula, hemothorax that will eventually get complicated through a retained hemothorax or a blunt cardiac injury resulting mostly in arrhythmia. The most common finding in patients with blunt cardiac injury is tachyarrhythmia, which is also a very non-specific finding, as you can see it in most patients, most trauma patients. When to suspect tracheobronchial injury. So a patient with tracheobronchial injury will usually have a large continuous air leak despite chest tube insertion. And the oxygenation will worsen after the chest tube placement. One of the very few indications to clamp the chest tube. So if you see a patient in the ED, we insert the chest tube and rather than improving, the patient starts to decompensate and he becomes more hypoxemic. This is when you need to consider clamping the chest tube because he's having a tracheobronchial injury and he cannot ventilate everything. All the air that is getting into the lung is getting out to the pleural space and to the outside. This is an indication to do main stem intubation of the unaffected side. So you would, let's say the pneumothorax is in the tracheobronchial injury is involving the right, you would intubate the left one. The hemothorax is a complication in patient post chest blunt chest injury. So any hemothorax should initially be drained. Anything more than 300 ml should be drained. Whenever we have a retained hemothorax, the patient will start forming empyema, which is initially exudative, then fibropurulent, then it will become an organizing hemothorax. These can be managed by observation if the hemothorax is less than 300 ml. However, any hemothorax more than 300 to 900 ml needs to be managed by a larger bore chest tube insertion and even possible decortication eventually. Not all the fluids from these retained hemothorax is positive for bacteria. So a negative blood culture does not rule out an infected hemothorax in those patients. because usually they are on broad spectrum antibiotic for different causes for open wounds, or they have initially received a large broad spectrum antibiotic at the time of the inciting event, which will cover eventually for the pleural effusion or the hemothorax they are having. At the end, I want to mention, it's not part of our scenarios, but I want to mention unstable spinal fracture that you need to be aware of in patients with blunt trauma. So we have three types of unstable spinal fracture. The first is a nodontoid fracture, type 3. So type 1 and type 2 are usually stable spinal fractures. That can be managed operatively or non-operatively. However, a type 3 fracture, which is a fracture through the odontoid and into the lateral masses of C2, is an unstable fracture. However, it has a good prognosis for healing. The second type of unstable spinal fracture is a cervical spine injury, which is called the Jefferson fracture. So 50% of patients will have associated spinal cord injury, as the canal will widen with low risk of spinal cord injury unless the transverse ligament is disrupted. So whenever the transverse ligament is disrupted, we need to suspect spinal cord injury. It may not be easily seen on X-ray, and this will require usually a CT of the spine without IV contrast. So they are easily missed. And the third type is a teardrop fracture. This is from flexion forces, and this results in ligamentous disruption and secondary instability. These are the three spinal fractures that to be aware of, and this is an indication to acutely or emergency consult a neurosurgeon or have him on board. And the last slide is a miscellaneous slide giving you things to look for whenever you have a lap seatbelt sign, a shoulder harness sign, or an airbag that was deployed. So whenever we have a lap seatbelt sign, we need to be aware of a tear or avulsion of the mesentery, a rupture of the small bowel or the colon, thrombosis of the iliac artery or abdominal aorta due to compression from the seatbelt, a chance fracture of the lumbar vertebra, which is a risk factor for a duodenal perforation, or pancreatic or duodenal injury, which are associated with the chance fracture. A shoulder harness is whenever we have sliding under the seatbelt, so the patient would slip when the seatbelt is not tight. And this will also result in intimal tear or thrombosis in the innominate, carotid, subclavian, and vertebral artery, because this will mostly involve a trauma to the neck. We will have a fracture or dislocation of the cervical spine, rib fracture, pulmonary contusion, rupture of the upper abdominal viscera. So this is more thoraco-abdominal type of injury. And lastly, we have the airbag. Whenever we have an airbag that is deployed, we need to be aware of corneal abrasions. So have an ophthalmologist check the eyes of the patient, specifically patients with contact lenses. And the patient who are reporting a change or an altered vision post-trauma, they will have abrasion to the face, the neck, the chest, and they may also have multiple facial bone deformities. They are at risk of cardiac rupture, cervical spine, and thoracic spine fracture. Thank you, everyone.
So thank you, Dr. Sarkis. This was a very nice and comprehensive lecture. Actually, we really appreciate the algorithms that you specified in the case discussion. I think we all really benefited from this. So it seems we don't have any questions in the chat box, but if you do, write them up. Otherwise, we really hope you're enjoying our sessions. This was a really nice and comprehensive one. We'll be moving on to some more specific topics in general surgery in the upcoming week. So we do have one question from Hamad Barakat. If a patient is considered non-salvageable, what do we do in this case? Do we move on to the next patient, or was that a byproduct of being in a crisis?
This is a crisis. So actually, whenever we have a patient who's presenting as a solo trauma case to the ER, we always we do everything that is possible. So even patient who present pulseless or post cardiac arrest, if we know that the patient arrested less than 15 minutes ago, we may attempt to do, for example, a left thoracotomy in the AD to try to diagnose any cardiac injury, do some cardiac massage, and then proceed from there. So we always do everything in our capacity. However, whenever you are in a crisis, for example, let's say in the case of the explosion, we have very limited resources in terms of material resources and in terms of physicians. I know we were in AUB and there was a lot of doctors, for example, in our case, but not everyone is used to handling trauma patients, and very few of us were able to handle trauma patients in a systematic way. Let's say do a fast, decide which patients need to go to the OR, which patients do not. So now, whenever we saw a non-salvageable case or a case that would require very extensive or heroic measures, for example, let's say putting this patient on ECMO, honestly, we were not very heroic as we usually do. I know it's sad, but this was, we saved a lot of lives at the expense of others.
So thank you. That was actually an interesting question. We have another one. What are the indications to place a test tube before X-ray in trauma?
Okay, so whenever we have a trauma patient who already comes hypotensive, tachycardic, he's already, let's say, in a class 3 hypovolemic shock, and his Glasgow coma is below 8, and he already got intubated, and despite that, he's hypoxic. So a patient that is on the verge of arresting, we need to be to trust our physical exam more than we usually do. So a patient with air entry on the left chest would warrant a chest tube or a needle decompression even without a chest x-ray, because a tension pneumothorax, I hope as everyone knows, is a clinical diagnosis rather than an imaging diagnosis. We don't do a chest x-ray to diagnose a tension pneumothorax. The chest x-ray would diagnose a regular pneumothorax. A tension pneumothorax is a pneumothorax that got the patient into becoming hypovolemic and almost on the verge of arrest. So this patient would warrant a chest tube without chest x-ray.
All right, so thank you everyone for attending and joining all of our sessions. And we'd like to thank you again, Dr. Sarkis. We hope to see you in our upcoming sessions as well. Have a great day, everybody.
Thank you, everyone. Thank you for being here.